Hello, my name is Ria Joseph. I'm a first-year medical student at Rocky Vista University, and today I will be talking to you all about Trenton. So here's Trenton. He is a 22-year-old Caucasian male who presents to the clinic with a dull, achy abdominal pain. He also reported early satiety, which means he feels uncomfortably full after a normal meal, and weight loss, even though he has not changed his diet or exercise habits. He has a history of occasional blood in his stool, which his college healthcare clinic told him was due to his diet high in spicy food. The only other thing we know about his diet is that he consumes Mexican food and cheap tequila more than he should. He recently graduated college and moved to Colorado from Oklahoma to work for a tech startup company. And then we also know that his parents recently cut him off financially because they want him to go to law school. These are our objective findings. So Trenton has a temperature of 100.2 degrees Fahrenheit, some minor abdominal distension, and a slight protrusion in his abdomen. So there's a lot that we don't know about Trenton in this case, but if I could, I would like to ask him about the location, frequency, duration, and severity of his pain. I would also ask him about any aggravating or alleviating factors, what the blood in his stool is like, and how much weight he's lost over what period of time. So we also know that he's having conflict with his parents, and I would want to know how that's affecting him overall, how he feels about the situation. And finally, I would also want to know about any family history of GI issues, autoimmune disorders, or cancer, because that history could be useful in narrowing down a diagnosis. So here's my differential diagnosis list. My working diagnosis is diverticulitis, which I will be talking about in more detail during this presentation. So Crohn's disease is an autoimmune disease, and it usually presents in people between 10 to 30 years old, so that's Trenton's age group. Typical symptoms can include a crampy abdominal pain, you could possibly have blood in the stool, fever, and weight loss. And these are all symptoms that we know Trenton is experiencing. Ulcerative colitis is similar to Crohn's, and both are considered types of inflammatory bowel disease. So they present with pretty similar symptoms. Peptic ulcers can cause epigastric pain, blood and stool again, bloating, and also alcohol is a risk factor for that. Then IBS, which is irritable bowel syndrome, can present with chronic or recurrent abdominal pain and can be exacerbated with stress. So if this is what's going on with Trenton, maybe the situation with his parents could be contributing to his symptoms. So again, I would just consider all of these diagnoses in Trenton's case, but today I will be just focusing on diverticulitis. So here are some basic terms that are kind of easy to get confused with each other because they're pretty similar words. But diverticula refers to the outpouchings of gastrointestinal lumen. Then diverticulosis refers to just the presence of these diverticula without inflammation. And diverticulosis can progress to diverticulitis, which happens if the pouches become inflamed. So diverticula form due to a mucosal herniation through the wall of the colon. The herniation occurs usually where the vasa recta pierce through the wall because the muscle layer is weaker at that point. And you can see that in the picture. The outpouchings are happening right where those perforating arteries are going through. So diverticula tend to form in parallel rows between the teniae coli, which are bands of longitudinal muscle in the colon. They're usually around 5 to 10 millimeters, but can potentially grow larger than that. And they're most common in the sigmoid colon because there's greater pressure in that segment of the intestines. This slide is showing how diverticulosis can progress to diverticulitis, which again is just the inflammation of those diverticula. So first, the diverticulum becomes obstructed with a ball of stool, which is called a fecalith, and this would start to erode the mucosa of the pouch. This can lead to inflammation, ischemia, and a high risk of bacterial infection. Other possible complications are perforation, obstruction of the colon, fistula, and phlegmon, which is inflammation of connective tissue, and an abscess. So relating this back to Trenton, an abscess can present as a tender mass, and maybe that would be the slight protrusion that was palpated on exam. So also the irritated diverticula can cause hematochezia, but this is not very common. Here are some symptoms and exam findings that we could expect to see in a typical patient with diverticulitis, and the asterisks indicate symptoms that we know Trenton is experiencing. So we know that he has abdominal pain, low-grade fever, occasional hematochezia, and then on exam he had that abdominal distension and a palpable mass. Risk factors for diverticulitis can include increasing age, constipation, low dietary fiber intake, obesity, lack of exercise, and NSAID use. There's still a lot we don't know about Trenton, like we don't know his BMI or his exercise habits. We do know that he enjoys Mexican food, quote unquote, more than he should, so we may have some dietary concerns there. According to an article in The Lancet, diverticulitis can be more harmful in young patients like Trenton, and there's a higher associated risk of recurrence or complication as opposed to someone who developed diverticulitis later in life. So we should definitely take his symptoms seriously, because if he does have diverticulitis, it's more likely to be more severe than in an older patient. For Trenton, I'd like to order a CBC to check his hematocrit and make sure he's not anemic or bleeding significantly internally. And I would look at the white blood cell count, because leukocytosis is reported in the majority of patients with diverticulitis. I would also order a C-reactive protein, or CRP, which, according to an article in American Family Physicians Journal, it can be highly suggestive of diverticulitis in patients with positive left lower quadrant abdominal tenderness, but no vomiting. I'd also order a BMP to look at his electrolytes and look at his renal function. Also a fecal occult blood test to see if there was currently blood in his stool. Ideally, I would order a CT scan, but an X-ray would also be an option for imaging. So some ethical considerations here would be whether or not Trenton should be exposed to the radiation of a CT scan, since he's a pretty young adult, and whether or not this plan would be affordable for him. So that's just something to think about in his case as well. And then just as another comment, a colonoscopy is usually contraindicated in symptomatic diverticulitis because there's a risk of perforation. This image is an example of what a CT scan might look like in someone with diverticulitis, and it's an axial view. So the arrows are pointing to the diverticula, which again are the little outpouchings of the colon mucosa. Okay, moving on to treatment and follow-up. So judging by the information that we were given about Trenton's symptoms, I would probably treat him on an outpatient basis to start off if his symptoms were relatively mild. So this would involve a clear liquid diet for 2 to 3 days. He could drink water, soup broth, fruit juices without pulp, and things along those lines. I would also prescribe an oral antibiotic, and the Dynamed Plus recommendation is 750 milligrams of ciprofloxacin every 12 hours and 500 milligrams of metronidazole every 6 hours. I would want him to follow up within 1 week or sooner if his symptoms got worse. And Dynamed Plus also recommended a follow-up colonoscopy 4 to 6 weeks after his symptoms have totally resolved in order to rule out malignancy. As far as patient education goes, these are some of the things I would like to talk to Trenton about. So again, we don't know much about his diet and exercise, but we do know that low dietary fiber and lack of exercise are both risk factors that can contribute to diverticulitis. Also, Trenton has an increased risk of recurrence due to the early onset of the disease. And as a fun fact, patients are commonly told to avoid eating nuts, corn, or seeds because they could hypothetically get lodged into the diverticula and cause problems. But according to a study in JAMA, there's no significant association between the consumption of nuts, corn, or berries with seeds with diverticulitis or complications associated with diverticulitis. So the study concluded that this recommendation to patients should definitely be reconsidered. I thought this was really interesting because working ER, I've heard several doctors tell patients to avoid these foods, but really there isn't much evidence to support that. These are some other important considerations to have in this case. So I've already mentioned the concern with radiation exposure and the cost of a CT scan. I'd also try to find out more about Trenton's current mental health situation. We know he's going through a lot of change with moving to a new state, graduating college, and he's in some conflict with his parents and he's no longer receiving financial support from them. But we're not really sure how he feels about everything and how that's affecting him day to day. He might be lonely, stressed out, or anxious or depressed, and these can all affect his physical well-being. I would also want to ask more about his alcohol consumption and find out if that has increased recently. And finally, I might be worried that Trenton wouldn't follow up, considering he is a younger patient and is probably under some financial strain right now. It's often difficult to convince people to go on and get a colonoscopy, so I would want to respect his autonomy with that, but also do my best to help him make an informed decision about his care. So again, these are issues that are kind of separate from his physical pain that he's presenting with, but they can all significantly contribute to his health. Here are my resources. And I'd just like to say thank you for Mr. Schwartz, Ms. Hefty, Ms. Fisher, Dr. Farrell, Dr. Ross for facilitating this program. And I'd also like to thank the audience. So thank you guys for your time.